Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
All right, wonderful, and welcome everybody. So happy that you found your way here so that we could all share some time having lunch and talking about advancing personalized care for prostate cancer using patient-centered solutions to address metastatic hormone-sensitive prostate cancer and non-metastatic castration-resistant prostate cancer. So welcome, and we're excited to have you here. My name is Alicia Morgans. I'm a GU medical oncologist focusing predominantly on prostate cancer care in Boston, Massachusetts at the Dana-Farber Cancer Institute. Again, I'm very delighted to be here and appreciate your attendance. And I'd love for the faculty to introduce themselves. I'll start with Professor Fred Saad.
Urologic oncologist and from the University of Montreal. Happy to be here.
Wonderful. Professor Gratzky.
Hello, Christian Gratzky from Freiburg in Germany, Black Forest.
Wonderful. And our patient representative, Mr. Tony Collier.
Good afternoon, and thank you for coming along to this talk. I'm Tony. I've been living with advanced stage prostate cancer for 8.5 years, so I'm hoping to share the patient experience with you.
I just want to emphasize the importance of having Tony here in the room with us. I think a lot of times we speak about what our thoughts are in terms of how important it is to involve patients in our treatment decisions. Obviously, they are decisions that these patients, our patients, are making, but it is really, I think, also very much recognized and acknowledged that a patient is taking the time out of his day to be here with all of us to share that perspective. So thank you, Tony. So thank you, welcome again. And I think just to set the stage, I think we recognize that prostate cancer is increasingly important in our clinical practices of oncology, of urologic oncology as well, and even in radiation oncology, nuclear medicine. This is an incredibly common disease, not just in the United States where I practice, or in Canada, or in Germany where my colleagues practice, but around the world. And we can see that the number of cases, 29.4 per 100,000, is large, and per recent estimates is absolutely growing as we see an aging population. The treatment landscape for advanced prostate cancer has also evolved quickly. Thankfully, for all of us, this has meant new developments, new approvals, new treatments, but also, importantly, we have to figure out how to work these new treatments into the paradigm of treating people with prostate cancer. And as things change, as we all grow in our resources, this can be quite complex, and that's really the focus of today. Further, the multidisciplinary team is increasingly being brought in to contribute here, and there are, despite these new collaborators, these contributions from our other team members, there are these unmet needs that we still need to face. So we need more multidisciplinary collaboration. We need to have more efficient integration of our novel therapeutics. We need to recognize supports that may be specific to an aging patient population, and of course, more therapeutics along the way. And now I would love to pass over to Professor Saad to talk with us a little bit more about metastatic hormone-sensitive prostate cancer.
Thank you very much, Alicia, and thanks for everyone for attending. So this will be very short and obviously highlighting some important data without going into much detail in the time we have, but hopefully we'll have some interaction with the audience and with the panel. So let's just start with a clinical case of a 68-year-old male who comes in with some urinary symptoms and some lower back pain. He has an abnormal DRE with a PSA at 47.5, and naturally went on to get a biopsy that shows, unfortunately, multifocal Gleason 4+5 prostate cancer. And workup, metastatic workup shows that there's enlarged nodes in the pelvis and retroperitoneum. No visceral mets, On bone scan, 3 lesions are suspicious of spinal bone metastases, and he has an excellent performance status. So, first question for this 68-year-old healthy male with metastatic prostate cancer, limited to the spine, which systemic therapy would you prioritize for this patient? ADT alone, ADT plus an ARPI, or more commonly called doublet therapy, or ADT, ARPI plus docetaxel, commonly referred to as triplet therapy. So if you can vote, and maybe I'll just start off with Professor Gratzky, for this kind of patient, without overly influencing the audience, what would you be doing for this 68-year-old very healthy male?
I have a very clear idea of how to treat him, because not only does he have a high PSA of almost 50, like Gleason 9, but he has retroperitoneal lymph nodes, and those concern me because they're associated with poor prognosis. So definitely opt for C, triple treatment. Triple treatment,
okay. And Alicia, in the States?
Yeah, I think this one's complicated because it looks like this may be oligometastatic. This pelvic nodal disease could often be included in a radiation field. I may go off perfect guidelines a little bit and get a PET scan to see actually how, PSMA PET scan to see actually how metastatic this patient is. Because sometimes we offer radiation metastasis directed therapy in addition to systemic therapy in this context. But I agree with Christian, a young person, de novo metastatic disease can consider triplet therapy. In more cases, we would probably do some combination of radiation therapy, ADT, and ARPI in my clinic.
Right, so we saw the votes probably represent what is actually going on around the world, where the majority would go with a doublet form of therapy because he's considered low volume. But I agree there are probably other ways that we should probably try to understand what this patient is going through and the likelihood of actually dying of prostate cancer. And we have to use that word. What is the likelihood of suffering and dying of prostate cancer? And think about what should we do up front. So as well as your choice for systemic therapy for this same patient, 68 years old, would you treat the prostate? So it's simply yes, no, or unsure of the utility of treating the prostate in this patient. Dr. Gratzky.
Based on the data that we have, I think if we don't do PSMA imaging, and according to what Alicia said, I'm fortunate to live in an area of the world where we have a lot of availability of PSMA PET scans, so we'd always do PET scan for that patient. But let's say he is oligometastatic, then I would actually always refer him to radiation therapy. There is not much evidence right now for the surgical removal of the prostate. There has been a paper out 2 weeks ago of the RAM trial in Germany that showed some benefit, but it didn't accrue the patients to a sufficient amount, so we can't draw any definite conclusions. So right now, as it stands, evidence points out that if patient is oligometastatic, radiation therapy could be an option.
Right, and I heard Professor Morgan's talking about consideration for MDT. I think that is still, the jury is out, but that is part of ongoing clinical trials. So the majority would consider treating the prostate, and there are some that would not be convinced. And just to maybe now come back to very, very quickly some of the data that supports at least doing more than ADT. This is from Stampede, which is some of the best contemporary data of men going on ADT alone for metastatic hormone-sensitive disease. And there are 2 things that are important to notice here. In the green line, you see that patients fail ADT within about a year, so 11.2 months for failure-free survival, which means they become castration-resistant in less than a year in all comer. These are not only high-volume or high-risk patients, and that's bad news. But the worst news is that when you look at overall survival, when you start with ADT, even though we have life-prolonging therapy for CRPC, patients only live 42 months. So that's 3.5 years, not much better than we did 20, 30 years ago when we only had ADT to use. And since then, we've learned that docetaxel can improve overall survival when you add it to ADT. And this was the first of the trials of Charted showing that there was a 39% reduction in the risk of death in the all-comer population compared to giving ADT alone. And so clearly this is an effective form of therapy. But soon after, what really changed the paradigm is the introduction of ARPIs. And here, 3 ARPIs came on board, all showing significant reductions in the risk of death, whether it was apalutamide, enzalutamide, or abiraterone. And this was a game changer, because even though docetaxel improved overall survival, there was a reluctance to getting docetaxel. So having an alternative that is better tolerated, less adverse events, was very attractive. But to say that docetaxel is not as effective as an ARPI is not what the data would suggest. The data would suggest that you actually have 4 very effective life-prolonging therapies that are possible to offer patients. So the question came, well, we have hormonally based, we have chemotherapeutic based. What about if we combine both and try to do the maximum we can do in patients that present with metastatic disease that might have hormone insensitive clones from the beginning, as we know is related to tumor volume? And 2 trials actually confirmed that you can do better than ADT and docetaxel. Did not answer ADT and ARPI, because in the era of these 2 trials, the best standard of care was ADT plus docetaxel. And so we added abiraterone in piece 1 and darolutamide in ARASENSE to see if we can do better than the very best standard of care that existed at the time of these trials. And the data supports that we can do much better with a triplet versus a doublet chemotherapeutic approach. Now, who actually needs chemotherapy is really the question that is still largely unanswered, but we know that patients with higher volume synchronous metastatic disease have the worst outcomes, and these patients really probably harbor the most amount of hormone insensitive clones from the beginning. And the idea here is that these patients are probably the low-hanging fruit that would benefit the most from a very aggressive upfront approach. And then on the other extreme are the low-volume relapsing patients, so patients who had radical prostatectomy or radiation, and then years later develop oligometastatic low-volume disease. These patients have good survivals or even excellent survivals compared to the other extreme. And then we have everything in the middle. So these are some ways of trying to help patients, because it's the patients who have to make the final decision. We guide our patients to what we should consider. Now, coming back to ARASENSE, where we have the study that actually was the first to really address this triplet versus doublet approach, clearly overall survival reduction of death by over 32%, but that was seen not only in the high-risk population, but even in the low-risk population. The hazard ratios were very similar to the high-risk, but you notice that median survivals haven't been reached at 5 years. So these low-risk patients with long survivals are the patients we might consider giving chemotherapy on top of a doublet approach. Now, what about the outcomes? And here, time to PSA progression is the first sign that things are not going as well as we would hope. And here we had a much better delay in PSA progression in the triplet versus the doublet docetaxel approach. But in both high volume and low volume, this benefit was seen. And obviously, I think we would probably agree that the high volume patient is the one who's going to benefit. But when you look at the low volume patient, you actually have 92% of patients that have no PSA progression at 5 years. That is amazing, to tell a patient that at 5 years there's no sign of progression, versus only about 35% of patients that have no PSA progression at 5 years if you're getting ADT and docetaxel alone. And the flip side of that is maybe that some patients we can consider actually stopping treatment. And that is one of my biggest motivations of being aggressive up front, is the hope that one day we can stop everything, ADT and everything that we're continuing to try to preserve quality of life while maintaining efficacy, and those are ongoing trials. And then we have a biomarker that we sometimes want to ignore, but PSA remains the best biomarker of response. And here, when we give triplet therapy, we get up to 67% PSA undetectable below 0.2. And why that's important is that time to PSA progression and overall survival are much better in those that get to below 0.2 compared to simply not getting to below 0.2. That is an important endpoint. Now, you can ask me, what do we do if we don't get to 0.2? I don't know. But that is what we need to be learning and working on, is what can we do even if we give triplet that don't get to below 0.2. And more recently, this was just published, that obviously there's a bias. Patients came into the study who were well enough to get docetaxel, but we didn't see any differential benefit whether they were below or above 75 years old in terms of the overall survival benefit. So these patients with metastatic disease are likely to die of the disease regardless of the age with which they present. And the adverse events above 75 or below 75 were very similar to those that didn't get the addition of darolutamide to the docetaxel. So I'll very briefly summarize some newer data from the phase 3 ADT plus ARPI in mHSPC, which is the ARANOTE study that was presented and published last year. So these patients had metastatic hormone-sensitive disease randomized to darolutamide versus ADT alone in patients getting always ADT as a base, with rPFS as an endpoint to be able to answer the question of the efficacy of darolutamide in these patients. And radiographic progression-free survival or death was reduced by 46%, which was statistically significant and led to the approval in many countries around the world. But some of the interesting points are, again, revisiting the undetectable PSA rates with darolutamide. And here, patients achieved this in 63% of patients on darolutamide compared to only about 16% of patients on ADT alone. But again, what does that mean for the patient? Patient who gets to below 0.2, the rPFS, 80% have no progression of PSA or radiographic progression at 3 years versus only 17 months to failure or progression of metastases if they are not getting to below 0.2. Time to mCRPC, PSA progression are much better in getting to below 0.2 than if you don't get to below 0.2. And I guess the take-home message is the way you follow patients that don't get to below 0.2 is extremely important because they will become castration resistant in 11 months. And they will have their first PSA progression in 14 months. So the way you follow these patients is extremely different. And this is, I guess, the theme of today is personalizing care, but also personalizing how we follow these patients that are not responding optimally. High volume, low volume patients do benefit from darolutamide, and in the patients with high volume, 54% get to undetectable versus 83% if you're low volume. And 54% is very, very good, but maybe these patients can get better results if we added docetaxel to the darolutamide, and that is where the question comes in, can we do better than monotherapy, ADT, and ARPI? And then in terms of the safety profile, without docetaxel was an opportunity in the ARANOTE study to really look at, what are we causing in terms of added morbidity by treating patients with darolutamide. And here we saw that the incidence of fatigue was actually less with darolutamide than with placebo. Obviously, darolutamide doesn't have less adverse events than a placebo, but patients can have fatigue because of cancer that is uncontrolled or less well controlled. And by controlling the cancer, patients complained less of fatigue. And this was unique in this study, that less patients complained of fatigue than with the placebo. So we're going to slowly go through every one of these trials. No, I only have 30 seconds left. But this is really just, if somebody is still wondering whether or not we can do better than ADT alone, please leave the room now. Because the data is overwhelmingly convincing that we can do much better than ADT alone. And how we choose to do and what we're actually going to do is extremely important for our patients' lives. Now, I'll just end with one last scenario. So this is the same patient, but instead of being 68 years old, this patient is now 77 years old. He's got multifocal Gleason 9 disease with metastatic disease in the spine. So how would that change the way you would treat this patient who's 77, ADT alone, doublet therapy, or triplet therapy? So while you're answering, maybe I'll ask Dr. Morgans, who...
I think that, especially for older patients, I do think a little bit more critically about chemotherapy, the supports they may have or not have at home, the other comorbidities, the possible impending frailty. So it's less common to give chemotherapy in my practice for a 77-year-old.
Right.
Couldn't agree more. The same recommendation for the patient. And this patient is on polypharmacy, so I guess in that situation, ADT and darolutamide would be a good idea.
Right, right. So, and I'm going to play devil's advocate here, where I actually would talk about triplet therapy in this 77-year-old. I'm not saying I would push if the patient is reluctant, but at 77, chemotherapy is going to be tough. It'll be even tougher at 80 or 81 when they'll be metastatic castration resistant. So I guess I want to throw a little wrench in that dogma that older patients shouldn't even be getting a discussion of chemotherapy, because most of these patients will progress. You saw the data that they will progress. And the older patient was studied in the stopgap analysis, and you saw that patients do benefit regardless of age, except for abiraterone. And this has been a little bit of a mystery. Why abiraterone doesn't lead to an overall survival advantage, even though prostate cancer specific survival is improved. And I have some personal theories that patients might not be followed as closely with abiraterone and prednisone, and that sometimes when they're doing well clinically and they're at 5 milligrams of prednisone, they might be developing, and we know that there are 12% grade 3-4 hypokalemia with abiraterone. So if I have an option, I would prefer avoiding abiraterone in hormone-sensitive disease. If there are cost issues, please go ahead. It's an extremely effective drug, but follow these patients closely. There is something going on in terms of overall survival with the abiraterone compared to the 3 amides used in hormone-sensitive disease. And this, for the ARANOTE study, we're presenting this here. It's not published yet. It's in the process of being published. But looking at the different age groups, and almost 30% of patients were over 75 in ARANOTE. And in terms of efficacy and in terms of safety, regardless of age, under 65, between 65 and 74, or above 75, was extremely reassuring that efficacy-wise, they're getting similar benefits, and in terms of safety-wise, didn't look like it was less safe. And we're actually looking at co-medications, and over 75, median co-medications were over 6. And this is becoming an issue in decision-making when we have to face these patients that are still well enough and will live a relatively long amount of time and that we need to act on. So thank you very much for your attention.
Fred, thank you, and wonderful. We're going to move into some expert quickfire. Round 1, there will be 2, so this is exciting. So let's see the first question, and you have 90 seconds to answer. What clinical criteria or biomarkers most influence your choice between doublet and triplet therapy for metastatic hormone-sensitive prostate cancer today? Christian.
Thank you, Alicia. So most of my 90 seconds would actually go to the discussion with the patient, because I think the question of whether or not that patient should receive chemotherapy needs to have a shared decision with the patient and his family, and that's the most important part of this. But if you go to clinical factors, as Fred very elegantly showed to us, the de novo high-risk, high-volume patient who is fit and who is going to accept the short-term toxicity for long-term gain, for me, is the ideal patient to receive triple treatment.
Wonderful. And, Fred, I'm going to pass this to you for a quick second before we get you back on the timer. There has been information about using Decipher or maybe MMAI type scores to think about chemotherapy specifically. I haven't seen that for the amides yet, but Any thoughts there? Are you using these in your clinical practice?
In Canada, we're a poor country, so we don't use many of the biomarkers that haven't been clearly established as level 1. But I think there's really some interesting work. But we do have other biomarkers. You know, I look at LDH, I look at ALK-Phos, I look at symptoms. Symptoms seem to be a really strong prognostic factor that a metastatic patient who comes in with symptoms is not going to do well at all. So there are some patients that really help us. And I look at PSA. When there's a discordance between the PSA and the volume of metastatic disease, so PSAs that are under 20 with, you know, extensive metastatic disease, that's concerning. It means there's a large proportion that aren't dependent on their adrenal receptor. You know, and that goes beyond, obviously, what Christian was saying. So I think we do have to think about how to better select our patients to inform them about chemotherapy.
Wonderful. Well, great. Thank you both for those answers. We're going to turn, I think, this one to Dr. Saad. How do you approach treatment intensification for patients with low volume versus high volume disease? Any tips for the gray zone of counting metastases?
Yeah, and you brought this up with PSMA. We don't know the number of PSMA positive lesions to call them high volume, low volume. So that's still a work in progress. But those gray area zones, you know, patients who are younger, and when I say younger, I'm talking about life expectancy. Long life expectancies in the low volume are very likely prostate cancer will be the cause of death. So these are patients who we'll seriously consider. And it's not because we give triplet that we won't treat the prostate. We do that. Triplet therapy, so very aggressive systemic, but still taking care of the local disease to try to maximize the long-term benefit.
Okay, great, thank you. What is your strategy in older or frail patients? Do you routinely use ADT alone, doublet with ARPIs, or triplet with chemo? Christian, I'll pass to you.
Thank you. So as we said before, and we know, and Tony just told us that in the UK you have just a survey where 50% of doctors prescribe ADT alone, which is actually a high number, and I was surprised. In Germany it goes down a little bit, but it's still way too high. I'm saying this because you saw all the trials, and if you look at the drop of PSA in ADT alone versus ADT in combination with anything else in combination is better than ADT alone. So I wouldn't do ADT alone at all. And if I have a frail older patient, I think this is a patient group we really have to get better. I would be very restrictive in using chemotherapy. There are elderly patients that would opt for this, but in general, I would be a little cautious and opt for a doublet treatment here.
Yeah, can I be provocative?
Sure.
If that patient is so frail that we're asking ourselves whether we should add an ARPI, we should probably ask ourselves if we need to use ADT at all. That might be provocative, but I have metastatic patients I don't treat at all because I'm so concerned about their frailty and having them just demolish. So, you know, I think if ADT you're convinced is necessary, it should be ADT and ARPI.
I think that's a good point. And just to add to that, you know, when we see some patients who are so frail but have no symptoms from their prostate cancer, we know that there are symptoms and decline that happen with our treatment. So it is important to consider this. And this is, of course, not the most common patient in our practice, but it is important for us to consider each patient's individual situation, and this is one that we do face. How do you select between ARPIs, Christian?
So generally, I think one can base their decision on safety or efficacy. Now, with safety, when you compare one RP to the other, one can look at maybe fearing rash with apalutamide or the cognitive disorders with enzalutamide, false fractures, while as by the books, as Fred Saad has shown us, with darolutamide, there is the least likelihood of having drug-drug interactions and significant side effects. They're all in the one-digit number, below 10%, except for fatigue, like 13%, so really not very high. But that's why I think while we can be clear that efficacy is very similar between the various drugs, safety profile is different.
Okay, thank you. All right, what are the most important predictors of early treatment failure, and how soon do you reassess for benefit? Dr. Saad.
Yeah, you know, obviously the most important is either PSA progression or radiological progression. And on these treatments, we have to be suspicious because sometimes they will progress radiologically without even PSA progression. But obviously, the nadir of PSA is very predictive of early failure. So how they respond is very clearly linked to how I will follow those patients, reassess for benefit, and ensure that they don't need more treatment earlier than patients who are getting an excellent response in terms of PSA.
Great. And Dr. Grotzka, I wonder if you could chime in about how often you scan patients if they still have a low or undetectable PSA in the metastatic hormone-sensitive setting.
We have a standard operating procedure where we do PSMA at the beginning of the treatment. And then I think everyone agrees that, and it doesn't matter which drug you're looking at 7 months, that PSA should be below at least 0.2. It would be better, preferably below 0.02. And then we wait for 3 more months when chemotherapy is done, and then we do another PET scan, regardless of PSA.
Okay, right, great. And I think it's important for all of us to recognize that scanning and imaging guidance was not actually formally necessarily in all of our guidelines, ESMO, NCCN, and others, but now have been more routinely integrated, suggesting these kinds of strategies every 6 to 12 months at a minimum from a temporal time point, that we repeat these because patients can progress with a low PSA.
Yeah. I think what's clear that you should not do is image before treating and image only at PSA progression.
Yes.
You need to have some imaging close to where you have the best response, somewhere between 6 and 12 months, to reset the clock, to really understand whether the patient's progressing or stable.
Get a new baseline.
Yeah.
Really important point. Thank you. With all the new therapies available, what is the most common mistake or pitfall you see in everyday metastatic hormone-sensitive prostate cancer management? Fred.
Well, I think it's undertreatment. Undertreatment is the most common mistake, and it's still, unfortunately, quite common even in countries where there's approvals and reimbursements, which is a little bit disappointing. But the common mistake is sometimes not looking. So patients are failing, and you don't image, so you don't know they're metastatic. Everybody's non-metastatic until you actually look for metastases, and so I think we have to be suspicious. And when I hear people say, well, I wait for a PSA of 10 or 20, I don't know where those numbers come from, right? I mean, when patients are failing, I think you need to trigger some imaging to see where they're at in their disease trajectory.
Thank you. And Christian?
So we have a lot of discussion in our MDTs about the fact that some patients might opt for stopping too soon because they're doing actually very well on the treatment. So PSA goes down, they're fine, they're going back to everyday life, and they're very often wondering whether just stop treatment after all. And I think there's a reason, and we only have the data that we have to base our decision on, and they have a continuous treatment option, and they don't have any intermittent or treatment pause option. There will be new trials coming up, but I think that intent to stop is very understandable, but it's not based on our data.
Thank you. And Tony, I wonder if you could chime in. What do you think is the most common mistake or pitfall in everyday management?
Yeah, I think certainly undertreatment in the UK seems to be a big thing. The National Prostate Cancer Audit, which was published last Monday, showed that over 50% of men with metastatic prostate cancer were being undertreated. And I do think that actually one of the big areas, and I'll talk about that later, is the fact that holistic care for men living with prostate cancer is substandard, in my opinion, and we can do a lot better, and I'll talk about that later.
Wonderful. Well, thank you. Well, let's move on, and we'll enter our next section. Professor Grotzka is going to speak with us about the non-metastatic castration-resistant prostate cancer landscape.
Thank you very much, Alicia, and thank you for inviting me here. These next couple of minutes will be on non-metastatic CRPC, and you're all from around the world, and regardless where you're from, in many countries, you will be saying, well, this indication doesn't exist anymore because what we're doing is a PET scan, and then we're hardly seeing these patients anymore. But I would like to bring up this question of whether or not doing a PET scan, seeing more metastatic patients, and then shifting this patient to a different tumor stage who will then receive a different treatment will actually end up in a better benefit and a better survival for the patient, because we don't actually know. Fred has shown us that treatment of mHSPC has become increasingly complex and difficult. But I think in this situation, complex is actually good, because it poses us questions. It is more time-consuming for us. And if you listen to the sessions here at this meeting, you'll hear those different modes of actions coming up. I think the next 2 to 5 years, we see many more treatment options for our patients, which is the reason why we're actually here. So we've heard about mHSPC. We won't talk about mCRPC, but we'll focus on nmCRPC. Much of this will revolve around the question about PSMA PET scan, and much of this is directed at asking about the PSA doubling time, the question how fast PSA levels are actually rising. Because it is actually a very aggressive state of disease. It's a silent state of disease. There's no symptoms. Patient is usually asymptomatic. Maybe he suffers from the side effects that he's had from his prior treatment to the prostate, whether it's surgery or whether it's radiation therapy. There's no radiologic evidence of metastatic disease with conventional imaging methods. PSA level is rising, and additional treatment is needed. The tumor has adapted to low androgen levels. So before entering the mCRPC state, that state, I think, is a very, very important one, because the patient looks at the rising PSA, doesn't see anything on imaging, and doesn't feel anything. And so he comes and asks for the best option available. And the reason why I was referring to the PSA doubling time, and I truly think that the doubling time is a very important factor. I'm not asking you now who of all of you is actually putting the numbers in a calculator or is just looking at the doubling time in a different way. But regardless how you do it, in men with CRPC, the doubling time is a strong predictor for the speed of disease progression in terms of development of metastases and overall survival. And if you have a short PSA time, and as you see in a second, the threshold is somewhere between 9 and 10 months, you are at greater risk of distant metastases. So here on the left lower side, it is stratified by less than 3 months, 3 to 9 months, 9 to 15, and then more than 15 months. You see this directly translated to the incidence of metastases. And on the right-hand side, you see why most trials use this 9 to 10 months threshold, because below that, there's an exponential increase of the risk of bone metastases, which is the reason why that, for us, seems to be so important and why this patient population is at risk. So I would like to present to you a patient. He's 70 years old. He had received external beam radiation therapy and ADT. At initial diagnosis, PSA was 11. Bone scan was negative for Mets. CT scan also negative for Mets. He had adenocarcinoma. His mother and sister were diagnosed with breast cancer, and his brother was diagnosed with pancreatic cancer. So after receiving the treatment, 2 years later, PSA levels normalized. He had castrate levels of testosterone, and then 4 years later, he was referred because the PSA was rising to an actually high level of 13 with a short doubling time, castrate levels of testosterone, and the scans still negative. So I think we would all agree that this is a typical non-metastatic CRPC patient. And now here's the question, and I don't know where you're all from, but in your opinion, should he have a PSMA PET scan, yes or no? I would like to make up your mind, and maybe you get different ideas now from the US and Canada. Alicia, how would that be in Boston?
I don't think that we would necessarily make systemic treatment decisions based on the PSMA PET scan, and we would use the PSA doubling time for that. But sometimes we use metastasis-directed therapy, and we add that on to systemic therapy in this setting.
Fred, Canada?
Yeah, this is a contraindication for doing PSMA in our center. If this patient has aggressive non-metastatic CRPC, the standard of care is systemic therapy, and PSMA, at least for now, outside of clinical trial, wouldn't change the treatment, because biologically, such a rapid doubling time, I think doesn't lend itself to metastasis-directed therapy.
Okay.
We would do it in a slow doubling time, where metastasis-directed therapy might make a difference, but we would never want to do metastasis-directed therapy and avoid early systemic therapy. The trials have shown, so I think Alicia's point is excellent, but would be systemic plus or minus MDT. That's a clinical trial question.
I mean, the question is, would it be a contradiction by itself? You could do the systemic treatment and add the metastatic.
Well, we don't have the evidence yet, but that is something that is being studied right now in the non-metastatic CRPC setting.
Fully agree, and that's the next question. And what we've seen, I think, all agree that we have an audience that come from countries where PSMA PET scan is readily available. Now, the next question, of course, based on this, most of you are doing PET imaging. In this patient, would that then affect your treatment strategy, yes or no? If you could make up your mind. I think we've talked about this. I think this is one of the areas in prostate cancer where there's so much controversy, which patient actually should receive metastatic directed therapy, in what form, but let's see what you said. So most of you who actually do PET scans will then base a different treatment opinion based on that result. That's interesting. Maybe we have time afterwards to discuss in your centers what you think that best option would be. And I'm bringing up this because our friend from Essen, Wolfgang Fendler, has come up with this enormously important trial in 2019 where they looked at 200 men with nmCRPC, very much like the approval trials, by conventional imaging that underwent PSMA PET imaging, and they showed that they were actually positive in 98% of the cases. So almost every patient did end up with metastases in that treatment cohort. And if you look at M1A, B, and C, they're all over the place. Cervical, thoracic, retroperitoneal, ribs, spine, pelvis, lung, liver, peritoneal. So this is not minimal. This really changes the aspect how you look at this patient. So it makes a huge difference. But I started off in my little talk by saying, well, whether this actually translates into better survival, now because we know and we assume he has more metastasis than we actually anticipated before, we don't know. And coming back to the question, which RP we should be using, there's a very nice trial where our chair, Dr. Morgans, was involved. Dr. George was the primary author from Duke. That group looked at, did a retrospective cohort trial reviewing electronic medical records. Those patients had nmCRPC and no prior NHA and had initiated novel RP treatment. If you look at the left-hand side, what you can tell is they looked at treatment discontinuation and progression. They had a composite endpoint for that, and they showed that very clearly to see darolutamide had the least likelihood of progression or treatment discontinuation in comparison to ENZA and APA. These are real-world data. And if you ask yourself why that was, on the right-hand side, it was usually because of adverse events followed by progression to mCRPC or death, and then they switched to different RP. That's what we know from nmCRPC, real-world data. It's a very actual study from last year. So I come back to my patient, and when we diagnosed him with nmCRPC, we gave him an RP on top of his ADT. But a year later, he complains about fatigue. And he says, it's not just that I'm tired, it's really that I'm having a hard time getting out of bed in the morning. So my question to you now is, when would you change treatment in this patient? Would you change treatment if symptomatic progression occurs, if metastases occur, or at the time of PSA rise alone if rising fast? If I can ask you for your opinion, and maybe I can ask Dr. Saad for his opinion about this question.
Yeah, so we would wait until there was evidence of metastatic disease. Basically, my practice is based on the clinical trials, and that's what we did in the clinical trials, is we waited for metastases to appear, and once it does, then we have to decide, do we do metastasis-directed therapy to keep them on, or do we go completely to another systemic therapy, which would be either chemotherapy or radium. Maybe one day in Canada it would be lutetium as an option, but yes, for now, we would be...
All right, then I think the audience is very much with us. I don't have much time left, therefore I'm concluding here by looking at the adverse event profiles of the various RPs in nmCRPC. So clearly in the Aramis trial, looking at DARA, which is confirmed by Arasense and Aranode, very few side effects. I noted this before, 13% fatigue, and everything else is below 10%. And if you look at the biggest, the most important side effects, they're very mild when the patient is put on darolutamide. But not only this, I think the drug-drug interactions, looking at the increasingly polypharmacy that we're seeing in our elderly population. Please note that abiraterone is put here. It's not indicated in that patient cohort, but it's put here for completion. But as you see, cardiovascular, hypertension, dyslipidemia, there are important drugs, everyday drugs, that you should avoid or consider modifying with apalutamide or enzalutamide, that you don't have to worry about with darolutamide. So I guess it makes life easier. That's the take-home message. But I think we are not great, at least in my center. We should better look at the polypharmacy and try to find out which drugs the patient are on. We have now a project with the local pharmacy to actually be much better using a specific software for this. But that's, I think, an important parameter to keep in mind. How often would you then perform monitoring imaging for these patients? Would you do this at regular intervals, regardless of PSA level, once at 6 to 12 months, then wait until PSA symptomatic progression, or wait until PSA symptomatic progression? Alicia.
Yeah, I think in this is still the non-metastatic setting.
Yes.
Yeah, so at this point, I typically, certainly at PSA progression, but I would probably repeat this about a year even without, and I would use conventional imaging. So this is where things get really hairy, I would say, in terms of PET versus conventional imaging.
We do very much the same conventional CT, and not Fred in Canada, same thing? Or?
It's the same thing, but just be cautious that on these ARPIs, PSA doesn't have to rise very much to develop.
Yes.
Median PSA increase in Spartan was 1.6. So really, it doesn't take much to develop metastases.
Yes.
All right, that's my final slide. I think we all agree on the fact that this is an important cohort of patients with a biologically very aggressive state of disease, the rising PSA, castrate testosterone levels, but no radiological evidence of metastases based on conventional imaging. We base our treatment decisions on patient-specific factors and disease-specific factors. We've talked about the use of molecular imaging, which will be more so in the near future. And I think we can't really give an answer to every question. And as we see, it's getting more and more complex, which is the theme of this symposium today. And by saying this, I would like to thank you for your attention.
Thank you so much. Wonderful. Thank you so much, Dr. Gratzke, and thank you for your presentation earlier, Dr. Saad. So we're on to quick fire. So which patients with non-metastatic castration-resistant prostate cancer benefit most from an early ARPI therapy integration, and when, if ever, do you adopt a watch and wait approach? Dr. Saad.
Well, clearly the data would support that patients with a doubling time of less than 10 months are the ones that benefit. Now, sometimes the question comes up, should we limit it to below 6 months or accept patients between 6 and 10 months? I think the studies do show that patients in both of those categories do benefit from early ARPI therapy, especially, and we put this in our Canadian guidelines, if they have a 5-year life expectancy. These patients will live a long time. So it's not necessarily for these non-metastatic CRPC patients that we want to treat everybody aggressively. But obviously, the flip side, a slow PSA doubling time, there's no role for systemic therapy at this point. Those are maybe ideal patients for metastasis-directed therapy.
Okay.
Based on PSMA, obviously.
Very good and within time. So excellent. How do you choose between ARPIs in the nmCRPC setting? I think we already talked to Dr. Gratzke about this. So Dr. Saad, what do you think?
This I would turn over to Tony. I mean, what's Tony's,
Yeah.
you know, these are patients that are asymptomatic. They come in and say, are you treating a number or a human being? And so we're only treating a number in these patients that have no symptoms and no metastases.
Yeah, I think the most important thing from the patient perspective is the best possible treatment that's going to enable them to live a longer life and live well with their cancer. So I'm not going to answer the question, I'm just going to make that statement.
So it really is the adverse event profiles, and then if they're taking multiple medications, looking at the drug-drug interactions that were alluded to. But we have 3 excellent drugs that all showed very similar metastases-free survival and overall survival benefits. So it's great to have options. Unfortunately, we have to make a decision. And so that's a shared decision, but I think, you know, adverse event profiles and drug-drug interactions will sometimes sway one over the other, but I really have used all three and have had really good success with all three.
Okay, great. And I would also add financial toxicity is something to consider, at least in the United States. As many of you have likely heard, we have an extremely complex healthcare system, actually, as do so many systems around the world, whether it's public or private, and all of these things come into play. But whichever one patients can also get is also, helpful. All right. How do you incorporate advanced imaging like PSMA PET into the routine management of nmCRPC? Is it standard of care or investigational? Christian, you didn't get to add your thoughts here, so I'll give this to you.
Thank you. Just because we use PSMA PET scan so much, that patient really doesn't exist anymore. I agree with Fred that if that patient is under treatment as an nmCRPC patient, then we would not do PET scan because it wouldn't make sense. He is on systemic treatment, and he has a fast rising PSA, so he needs systemic treatment anyway. But just because we do this beforehand, that patient is very likely to be switched from nmCRPC to mCRPC. I think in a perfect world, we would do PET scan imaging in a high-risk patient, not in every patient, but a high-risk patient at initial diagnosis, and when changing treatment lines in a later line. Because then, of course, you base your decision on your PET scan. I know this is not available everywhere, but I think if you look at Australia, for example, even though PSMA was developed in Heidelberg, it was really the Australians who made it big, who did the trials, so a huge, impressive effort by the Australian colleagues. They do, in every prostate cancer patient, only PET scan with PSMA. That's what they do. I think that's the way to go.
Okay. Any other comments there, Professor Saad?
No, I just want to reassure the countries that don't have easy access to PSMA that it's far from standard of care for now. You're not under-treating or not treating well your patients. But when you have it, I think it's a great investigational tool to see if we can do better than the systemic therapy, but it does not replace systemic therapy.
Yeah, I think this is such an important point. These trials were designed before PSMA PETs were a part of our commonplace, and the trials included patients who had conventional imaging that was negative. Systemic therapy in this setting improves not only metastasis-free survival, but overall survival. We cannot lose sight of that key message. Anything we do with a PET scan is over and above what we should be doing when it comes to that rapid doubling time and adding systemic therapies, combination systemic therapies in this setting. So I think that's the most important message. And we function before PET scans. We will continue to function after, and we'll function everywhere in between, especially as the logistics are still being outlined and our understanding of what a PET scan means at baseline, progression, et cetera, is also still being defined. So we have a lot to learn. But systemic therapy combination, ADT and ARPI and non-metastatic CRPC is absolutely standard of care. So that's fantastic. And so, Tony, you're up.
Good.
Come on down. So this is our patient advocate, Mr. Tony Collier. Thank you so much for being here. Thank you.
Good afternoon, everybody, and I'm very pleased to be here representing the patient voice. I'm a trustee of Tackle Prostate Cancer, which is a charity in the UK. And we look after 150 prostate cancer support groups across the whole of the UK. And we are the only patient-led charity that does that. So the voice you're going to hear today isn't just my voice, but the voice of the thousands of men that we represent. I'm going to talk a little bit about my own cancer journey. Think about the patient healthcare professional partnership. Take a look at personalised holistic care, what we can do better, and think about changing holistic needs. So this was me in 2016. I just completed the Comrades Ultramarathon in South Africa, 56 miles, 6,500 feet of climbing, and it was 30 degrees centigrade. And the following year I was going back to do it again, but then cancer struck. So training for an ultramarathon, I had a groin strain. The groin strain was diagnosed via MRI scan and shown to be metastatic prostate cancer throughout my body, from pelvis to skull, in nearly every bone, and I was asymptomatic until the groin strain started in the February, before my diagnosis in the May. I was given a worst case prognosis of 2 years. I was given a best case prognosis, but I didn't hear that. I only heard 2 years. I was due to start docetaxel in August 2017, but thankfully my medical insurers funded abiraterone for me. And that was my first encounter with healthcare inequalities, because abiraterone wasn't available in the UK until last year, over 7.5 years after my diagnosis for men with metastatic prostate cancer. I got that drug because I had private medical insurance. My diagnosis was de novo stage 4. I was age 60, PSA of 129, Gleason 5+4, and extensive mets throughout the skeleton. And I started ADT immediately before going on to abiraterone. I've been on ADT and abiraterone ever since. And I'm pleased to say that my PSA level has remained undetectable now for over 8 years. So this has a massive impact on day-to-day life. It's very challenging from the perspective of the patient. If we think about the sort of impacts, I don't think immediately after my diagnosis I was the same man. I lost my body image. I gained a bit more around the waist because of treatment. I gained man boobs. And this was really difficult for me to cope with. And as an athlete, I became a back-of-the-pack plodder, having been a very good club runner. If we think about family, prostate cancer affects the family, the whole family, and it affects relationships. And marriages break down because of a prostate cancer diagnosis. And that's why we need better help and more holistic care. I thought a lot about not seeing my only grandson grow up. He was 3 at the time. Thankfully, I now have 4 grandchildren, and I feel very blessed. Finances, huge cost to the patient and to the healthcare system. It's cost a fortune to keep me alive, and it's cost me personally a fortune during the period since my diagnosis. Then sexuality. As you know, prostate cancer affects sexuality, but it impacts both sides of the relationship. It's impacted my wife, who was 58 and very attractive, and to be told all of a sudden you've got no sex life again because you've got no libido and you're on this treatment was really difficult for everybody to take. So I'm going to talk about the relationship between patients and healthcare professionals. This needs to be a true partnership. We need shared decision making. We need to trust each other. This is really important because I've put my life in my oncologist's hands. We need to be open and honest with each other. We need to know about all treatment options, not just the treatment options that your cancer centre offers, but all treatment options. That doesn't happen. We need recognition of our holistic and changing needs, and that's also an area where I think we can really improve. And we need real personalised care. And that's what it should look like, but the reality is different, I'm afraid. So let's have a look at what personalised care looks like. I pulled together some definitions. I'm not going to read them out. I'll leave you to read that for a couple of seconds before I move on to the next one. But you'll see that I've highlighted some key words, and I'll come back to those key words. This is the second definition. And the key word here is about empowerment, about empowering your patients. Giving patients choice and control. Shifting power, giving patients a voice. And then I pulled all that together. And here's my challenge to you. In your clinical practice, do you achieve all of that? Because from the patient perspective, that's not what we're seeing as patients. What we need is true personalised care that covers our changing needs. My recommendation, and we are now starting to do this more in the UK, is that we should have a holistic needs assessment within 9 to 12 months of diagnosis. But that then needs revisiting. So at the moment we're doing it at the point of diagnosis, but not doing it later in the period. And Our needs change, so that holistic needs assessment needs to be revisited on a regular basis. We also need information. I don't have access to my medical records, either at my cancer centre or in primary care. We have primary and secondary care systems that don't speak to each other. It's really frustrating. So I went to my GPs and they asked me how I'd recovered from my prostatectomy. I didn't have a prostatectomy. I was stage 4 at diagnosis. Digitalization of records, this is really important. I go every 12 weeks to meet my oncologist, and then they write a letter to my GP, and they send a copy of it to me. Someone's had to type that. Someone's had to post it. Why not just digitize it, make life simpler, give me access to it, give my GP access to it, so that we're all completely up to date. A single point of contact to improve communications. The role of the clinical nurse specialist is absolutely vital in this. I had a wonderful CNS right at the start. I don't have one now at all. More choice and a shift to empowering patients. Let us have more control, but support that control. But some patients, unfortunately, don't know what to ask. So my advice to you is don't shy away from really difficult conversations, particularly conversations about sexuality, about psychosexual support. And then my other piece of advice would be, please signpost your patients to support without being asked, because some people are not able to advocate for themselves, and therefore they need you to be their advocates. So please signpost them. Improve your awareness of mental and sexual health. This is really, really important. My wife and I were very fortunate to be able to access psychosexual therapy, and that's been an absolute godsend for us. It enabled us to keep our relationship together. It made us realize that intimacy was just as important as actual physical sex. But we had to ask, we had to advocate for this ourselves. We need you to be our advocates. And finally, on that section, please don't overprotect us. We are remarkably resilient. We can still do incredible things. And since my diagnosis, I've run another marathon. I've run a 100-kilometer ultramarathon. And in 2022, I ran 5 kilometers a day for 365 continuous days, raising money for cancer charities. So we can still be remarkable and we can still be resilient, so please don't overprotect us. And these are the changing steps of the pathway. I would like to see holistic care at every point through the cancer pathway. How can clinicians better support their patients? Recognize that these are life-changing, potentially life-ending events. Recognize that our needs change and have changed, and support that need holistically. Advocate for your patients so they don't have to self-advocate. Far too many cancer patients are having to self-advocate, and regrettably, some people are not able to. And that's why we see so many healthcare inequalities, and particularly in areas of where we have poor socioeconomics, and in the UK we have a real big problem in the black communities, where we are seeing more and more healthcare inequalities. And my closing message for you all is please, please, please remember to treat the person, not just the cancer. Thank you.
That was fantastic. Thank you so much, Tony. I so appreciate you, again, taking the time to share your perspective and the perspectives that you've heard from the people that you work with and support in the UK. And I think we'll certainly include you in our ongoing conversation, because one of the things that we also wanted to touch on in this discussion today is the importance of having this multidisciplinary support. So Tony mentioned psychosexual support and that psychological support, in addition to all of the other people that come onto the team, the urologist, the medical oncologist, the radiation oncologist, the nuclear medicine doctor who may be supporting in terms of understanding the PET scan. There also, I think, is an important genetics team that is increasingly involved in our care of metastatic prostate cancer, soon possibly in metastatic hormone-sensitive prostate cancer, but certainly in metastatic castration-resistant prostate cancer. Our cardiologists who can help us as we try to keep our cardiovascular health in line, physical therapists, pathologists. But the most important person in this is the patient, and thank you, Tony, for helping us remember that we do need to keep that patient centered, treat the patient, treat that person, not just the disease. So as we kind of round out some of our conversation, I wonder, Christian, if you have any comments on anything you'd want to raise to the group or to touch on.
I do, because first of all, thank you very much, Tony. That was very impressive. I need some moments to digest, I think, for everyone. What you said about the running impressed me very much. I mean, you did it before diagnosis and after. And I think everyone heard the trial at ASCO in colon cancer, where exercise actually leads to an overall better survival. We are not doing great in getting data for physical activity in all different stages of cancer. We're right now setting up a trial called the Energy trial, where we do neoadjuvant physical activity before prostatectomy. But especially in later stage disease, I think, and it's also interesting about endurance sports and strength sports, you know, because there's different aspects to this. I think endurance is one thing, but the strength part, especially in somebody who has sarcopenia and loses muscles, I think the importance of doing sports is enormous, and we don't have any data to support this.
If I could just come in on that, I saw exercise as my way of taking control of my cancer rather than being controlled by it. And I've been a massive advocate for men living with prostate cancer to get more exercise. In Greater Manchester, where I come from, we have a cancer prehabilitation program that I'm one of the 2 patients on the steering group of. And we are seeing amazing results in people going through prehabilitation before cancer surgery or treatment, saving the National Health Service about £1,000 per patient that goes through the program. But frustratingly, we aren't able to get that funded properly, and it's really, really upsetting because we see the fantastic results exercise can have.
Yeah, this is part of our program at our center. We actually have physical therapists, because on hormone therapy and ARPIs and even chemotherapy, what we're seeing is what makes these patients feel the best and resolve the fatigue was actually exercise. And we did do an effort with Movember with a large randomized study of exercise supervised versus exercise on recommendation. And we're going to start reporting some of that data. But we're actually, in the mouse, it looks fantastic. I mean, it makes the mice that we put on exercise compensates for poor diet in terms of cancer growth. So really an anti-cancer effect, like you're seeing in colorectal. And that was a Canadian colleague that's actually involved in the metastatic study that we're doing. So I think exercise over and beyond the physical, the physical and mental well-being might actually really have some anti-cancer properties, and some of the in vitro work is really quite impressive, where we get metastatic CRPC patients doing exercise, we take their blood and we put them in contact with the cell lines, and the cells really slow down their production. So there really is some cytokines, myokines. There's a lot that can be said, but clearly exercise is part of our program. Yeah. And you know, the reality here, and this is a great slide, is that a lot of centers might not have access to all of this, but now we have access to other centers. We have to create teams that do have these opportunities. There is no longer, with all the virtual ways of communicating, we can get access, and it's unacceptable that we don't at least make an effort to create these teams that might not be physically in our own center, but collaborate with others.
I spoke about psychosexual support services and how beneficial that was for my wife and I. But actually psychological support is also incredibly important. The suicide rates amongst men with prostate cancer are far higher than in the male population in general. And In that first 18 months after my cancer diagnosis, I thought so much about dying that I actually forgot the joy of living. And I realized I needed help. And I sought help because it's a sign of strength to do so. So what I would be saying to you is just watch out for your patients' mental health, because it is really, really challenging living with metastatic prostate cancer because of all the other impacts that you get from the treatment. So I think psychological support is absolutely vital, and probably at a reasonably early stage.
Mm-hmm.
So then thank you for sharing that, Tony, because I think importantly, hormonal therapy increases the risk of things like depression by, say, 20 to 40% across different studies. And these are only on diagnoses that we capture, and I think mental health is something we often don't capture. So it's really critical. One of the best ways to combat psychological distress, in addition to getting support, counseling, and pharmacologic management, is through exercise. And for those who don't know about the study in colon cancer, there was a study for patients, I believe they had stage 2 colon cancer, perhaps it might have been some stage 3 as well. They were getting adjuvant chemotherapy for their colon cancer, and they increased whatever physical activity they had been doing by 150 minutes a week. So whether they were couch potatoes before and increased to 150 minutes, or whether they were already active and increased by 150 minutes, didn't matter. All of these patients increased by 150, and then there was a decreased risk of recurrence. When we're treating patients with hormonal therapies, perhaps we are going to have better cancer control, but we absolutely can have better psychological health, and we can certainly prevent some of the negative metabolic changes that happen when we lower testosterone. These include things like increases in cholesterol, decreases in muscle mass, and atrophy of muscle mass, increases in things like sarcopenia. So advocating for exercise, physical activity is so important. So please do keep this in mind. It is probably one of the most effective treatments that we have, and it doesn't come in a bottle. So it comes with our support and our recommendations. Now, there was a question for Tony. I'd love if you can share a little bit more about what you mean by holistic care. We appreciate that you're recommending it. How do you define that?
So holistic care is really about all our needs. It's about basically everything that you see on the screen. So it's about our mental health, it's about our physical health, nutrition, exercise, sexuality, psychosexual support, but remembering that there are two parties in a relationship. So it's about all our needs, not just treating our cancer. So think about everything that impacts people living with cancer: mental health, physical health, sexual health, and make sure that you're supporting in those areas, because certainly in the UK, sexual and psychosexual support is actually really challenging. It's not psychosexual support, it's basically not available unless you pay for it. And so those are what I mean by holistic needs. It's everything apart from the cancer, it's everything else.
One comment I would make on things like physical activity and sometimes mental health supports, that we are also finding these in our prostate cancer support groups. They can form sometimes exercise groups, but they can also have these virtual meetings where they may provide some psychological support for each other. This can also be helpful. I encourage each of you in your own areas to talk with your patients who may actually be able to share resources that are available in your local community that you may not even know about, that may be low cost or no cost. In my area, this is in the United States, this is often provided through programs that can provide opportunities for patients to go to a gym or meet with other cancer patients, not necessarily prostate cancer patients, for low or no cost. But this is available in certain regions and communities around the world, and our patients may actually be able to share some of these resources with us if we ask, and then we, of course, can share those with other patients. Fred, did you have a comment?
No, I totally agree.
Okay.
One thing that actually we are finding more and more helpful in the UK is peer-to-peer support. So Tackle, the charity that I'm a trustee of, is now developing its own peer-to-peer support program. So a man newly diagnosed with prostate cancer will be linked to one of our mentors. And I speak to men all the time. I had one man contact me out of the blue completely. He said, "I've just been diagnosed with metastatic prostate cancer and I keep thinking about suicide. Would you please talk to me? Would you meet for a coffee?" And we've become good friends. And I think that peer-to-peer support is really, really important. So linking people through mentoring services, can be significantly beneficial for the patient.
Okay, thank you. In your work with Tackle, is health literacy ever an issue for people with prostate cancer? And how can healthcare providers support that particular issue, given that, especially even adhering to your treatment plan and making sure that you manage your side effects can be dependent on health literacy?
I think health literacy is definitely a problem. It's quite a major problem. And we are seeing in the UK significantly worse results in areas of poor socioeconomics, in certain ethnic communities. And a lot of it is to do with literacy and health literacy. So when we've considered this previously, we found that one of the best approaches is to consider how a patient might absorb information. And I remember back when I was diagnosed, it was, here's a load of booklets, go away and read them, and that isn't good enough. People absorb information in many different ways, and if they struggle with literacy, maybe things like videos would be a really, really helpful media to use. Diagrams. I think just think about all sorts of media rather than just written word, because the written word is not easily absorbed for some people. And yes, health literacy is a significant problem.
Yeah, and I think ongoing support and referring people sometimes to patient advocacy organizations where they may have some plain language images or summaries to help people is also one of the strategies that I use.
And the patients have to understand why we're doing what we're doing and what. So if the patient clearly doesn't understand, we have to find some way, whether it's the family, and if it's not possible with the family, these are the patients my nurses spend the most amount of time with. When I don't feel that I've gotten through 100%, these nurses are absolutely essential, and that's where they need to invest the time.
Yeah, it's such a great point that we can lean on the other members of our team.
Absolutely.
When we feel like we're not getting through, the other members of our team sometimes can. And if they can't get through to the patient themselves, then maybe they can get through to the adult child, the adult in the family, like a daughter or a son, or perhaps a spouse or partner who's there in the room too. So thank you.
We've certainly found that very beneficial in the prehabilitation program, particularly when COVID struck and we had to go to a digital offering. And lots of the people were frail and elderly and couldn't cope with the digital offering. So actually talking to their children and getting them involved was incredibly helpful at communicating the message.
Okay, one more question. This is going to be rapid fire, even though I don't have the 90-second timer. So for each of our clinicians here, if a patient progresses on triplet therapy, which would be ADT chemotherapy and one of the ARPIs, what's the next step? Christian?
So depending on the healthcare system you're working in, you have several options. In our country, it's really about lutetium PSMA versus cabazitaxel versus PARP inhibitor. So based on the therapy trial, it seems like lutetium PSMA has some advantages over cabazitaxel, and also the patient is just coming off chemotherapy, so you might not opt for the next one right away. So then it's about lutetium PSMA versus PARP inhibitor. Based on the novel, trials that we've been seeing, most of them actually will opt then for PSMA lutetium. That's what the reality is in our country.
Okay, and Professor Saad?
Well, the field is trying to better understand who these patients are and why they're progressing, and what are their resistance mechanisms. And I agree, if they have a BRCA mutation, you know what to do. But I think this is where the field needs to go, because after triplet therapy, there's a huge heterogeneity, and we have to understand what we're treating to choose the best option.
Yes, and molecular markers, something that we can target more specifically, is hopefully going to be the way to go. And whether you have access to radium or combinations of PARP and an ARPI, we all are in, and chemotherapy, of course, we're all in different practice settings. So these shared decisions are going to be really impactful when had with the patient, with all the information that you have in hand now. So I would like to say thank you so much to all of you for taking the time to, of course, find this session and then stay with us to have a wonderful conversation. Thank you so much to Professor Saad, Professor Gratske, and most importantly to Tony, who's flown here just for this, to spend his time with us. So let's give them all a wonderful round of applause.